All right, that was an amazing opening panel. And it's all upward well, it's going to be hard to keep that momentum going, but we're going to give it a try. Our next panel is called Creeping Privatization. And I'd really like to thank our friend Kevin Scarrett for filling in for Natalie Mara and for hosting the panel. And I'll hand it over to Kevin.
Thank you, Steve. Is this on? Can people hear? This need to be close to the mic to speak right into it. Thank you very much, Steve. Thank you to Canada Health Coalition, panelists, and everybody attending. This is, to my mind, very clearly a very important session and an important day-long conference. This session, as you'll see from the material, is focused on privatization. The title, as Steve just said, is Creeping Privatization. When I saw that title, I thought, you know, that is one way to look at it. I'm involved with Ottawa Health Coalition and Ontario Health Coalition with Natalie Mara and others. We tend to view it more as a galloping away process rather than creeping. But this is all an interpretive exercise. But I am really honored and happy to be filling in for Natalie Mara as moderator of this session, and really just here to introduce a terrific group of panelists. We have sort of three segments here, four speakers. I won't go into the description of each session. It's here, and I'll leave it to each of them to kind of introduce themselves and their background in more detail. I'll only slip in one point of my own as part of this sort of setup that I think folks may find of interest. I already had my little rant about nurse practitioners from the microphone. One other element that we are facing and have been grappling with here in Ottawa, and I recognize a number of you are Ottawa-based, so you'll know this, but those of you outside may not. We have one of the more disturbing examples of hospital sector privatization unfolding right here in Ottawa at the Riverside campus of the Ottawa Hospital. And it comes in the form of a new surgery company that goes by the name Academic Orthopedic Surgical Associates of Ottawa. That's it. AOAO. This is a company that we learned through a media leak last February was about to start performing orthopedic surgeries inside the Riverside campus of the hospital. And it did start that. It has been performing on Saturdays and recently expanded to Sundays, weekend surgeries. I just want to share that because I'm a researcher type. I'm not a healthcare specialist. I kind of focus on pensions, but I dabble in healthcare. And I just want to share this one detail that I learned from digging into this company and who's behind it and how this arrangement was set up. Because, you know, what this means is we have a private for-profit corporation performing surgeries in our public hospital. There's some kind of rent arrangement, a lot of the financial details not disclosed, all considered secret, very disturbing. This is the detail. Looking into the company itself and some limited reporting in the media, what we learned is that the company was formed by 8 orthopedic surgeons from the Ottawa Hospital. And the chair of that company, the chair of the board, some of this was required legislatively to be disclosed. The chair of the board of this company is a doctor, a surgeon by the name of Dr. Paul Boulay, who until recently, until this company was formed, was the chief of orthopedic surgery at the Ottawa Hospital. He was recently also named chief of staff at the Hawkesbury and District General Hospital in Hawkesbury, east of here. And he is also the director of research and innovation at the University of Ottawa's orthopedic surgery section. So he has these 3 jobs in these public institutions, including our public hospital, including as a lead surgeon. And he is now the chair of a private corporation that has signed a secret contract with our public hospital to perform these surgeries right inside the hospital. The way I kind of half joke, but it's only half with people about this, is we have a group of surgeons working for our public hospital that have privatized themselves and contracted with the CEO of the Ottawa Hospital to actually perform these surgeries. I just share that as my one little disturbing detail. I think some of the content of what we're about to hear will provide further elaboration of these kinds of trends. I'm going to stop there and just get right to it. I think we're just going to go in the order that I have. I think, and I didn't check with our speakers, but Andrew, if it's okay with you, I'm going to invite Andrew Longhurst to present. Andrew is a political economist, health policy researcher, and PhD candidate in the Department of Geography at Simon Fraser University. He's going to be speaking about a report that I know and have read, and he was the lead author on Blurring the Lines, Healthcare Outsourcing and Private Payment. I'll turn it over to Andrew now. Reminder, each speaker has 10 minutes, or each segment has 10 minutes. Yeah, I'll try to give you a nudge, Andrew, if you go past that time.
Thanks, Kevin. And I've got my timer on. I just did a talk in Peterborough and I had 40 minutes, so I will not go that long for sure. 10 minutes. I want to, in the time that I have, I do want to talk about, I think, what we are seeing in the wake of CAMBI is a bit of a recalibration of corporate strategy, strategy among some physicians and surgeons who are investors or more entrepreneurial and interested in ownership and investment in private for-profit facilities. And I think increasingly we're seeing this blurring between outsourcing or contracting out the use of public dollars for publicly funded insured services, and the blurring of the boundary between that and private payment. And I only will have time, I think, to talk about some of the case studies in BC, but this is a topic that I've been following and publishing on probably for the last close to a decade. And I think we're at a point where in the wake of CAMBI, we're seeing increasing movement in this direction. And I think there's an effort to really kind of blur what we understand as outsourcing and how that starts to encroach upon or become two-tier healthcare or unlawful extra billing. So I know most of us in this room, or probably everyone in this room, will know the difference between private financing and private for-profit delivery. So I'm not going to spend much time on this, but these are the two forms of privatization where I think we're starting to see, or we have been for some time, but I think increasingly movement to sort of conflate both of these, to say that for-profit delivery and the use of public funds is really just part of public health care, and that it has nothing to do with private financing and two-tier healthcare. And I hope in the time that I have to convince you that I think that's not the case. And we have evidence largely driven by freedom of information requests and triangulation with public payment data that comes out of the provinces, but also the great resource of the Health Canada Health Act annual report to be able to make sense of, I think, some of the shifts that we're seeing. So I would say in the early 2010s, we started to see quite a significant movement towards a much greater outsourcing with the use of public dollars for publicly funded, insured, and medically necessary diagnostic and surgical services primarily. There's been early experimentation in BC as well as in Saskatchewan. And we're now seeing, as you'll know, to colleagues in Alberta and those that are familiar with what's underway with the Alberta Surgical Initiative, quite an effort in that province. And more recently in Ontario, where my work has turned more recently, a real effort to expand the role of for-profit involvement through OHIP-insured procedures, both on the diagnostic and surgical side. And I think increasingly a similar discourse around the fact that, this is just public health care. There's nothing wrong with this, and it's quite benign. So this is I think a quite useful nugget that comes out. Again, I'm so grateful that we have the Canada Health Act annual report. This is reporting or a letter from the BC Ministry of Health that is appended in the annual report. And I think this sort of explains the rationale that we are hearing increasingly. And I'll quote, the BC Ministry of Health has increased health authority contracts or extended additional contracts to private surgical clinics found previously to be extra billing. These contract additions should eliminate an approximate equivalent in private billing. With these contracts, the health authorities have moved from short-term to multi-year terms of service, and the stability of these contract arrangements will keep former private capacity in the public system in a sustainable manner. Overall, the ministry views this current productive dynamic between health authorities and clinics, formerly providing private services, as demonstrative of the value of contractual arrangement to bring private surgical services back into the public system. This approach simultaneously eliminates extra billing practices and enhances the capacity of the public system to provide needed patient care. And that's from this year's annual report. So indeed, in BC, we've seen a significant growth of outsourcing, both on the surgical and diagnostic side. Overall in the province, much like we see in Ontario, the weight of that public funding for insured services is on the diagnostic imaging side, but we've also seen in terms of the growth rate, the most significant growth on the surgical side. And keeping in mind, in BC, we've seen a doubling of the share of total surgeries delivered in for-profit facilities. And we can contrast this with Alberta, where it's closer to 20%. So good to, I think, keep that in mind, but nonetheless, significant growth in British Columbia. And in BC, this is, I think, really what I hope to convey is there has been quite an evidence and a fact pattern of these very for-profit clinics that are in receipt of public funding engaging in unlawful billing. And I think BC is an interesting case because we have had a provincial government that has been perhaps one of the most collaborative in terms of working with Health Canada to estimate how much extra billing is happening in the province. And I don't know that the same can be said for other provinces. That being said, BC is also a province where we have a well-established for-profit surgical and diagnostic sector, and a long-standing, it's no surprise that the Canby litigation came out of British Columbia. This is quite a well-entrenched physician and investor-owned for-profit sector. So it is the province over the period 2016-17, 2022-23 that's had the most extra billing in the country. And this is based on the sample methodology arrived at between Health Canada and BC. There have been 12 private clinic audits conducted between 2017 and 2022. And as I mentioned, this work it's challenging across the country because understanding the clinics and facilities that are engaged in extra billing often, or I should not say often, always requires the use of freedom of information and research methods that allow you to actually understand what's happening. Because none of this is publicly reported, we aren't able to triangulate the facilities that are in receipt of public contracts with those that have engaged and been found to have engaged in extra billing. And as I said, BC is interesting because there has been a number of private clinic audits conducted in the province where I've been able to piece together this story of them in receipt of public dollars, but also having been found to engage in extra billing. One of those is Falls Creek Healthcare Center. This was not too long ago acquired by ClearPoint. This is the private equity-owned chain that now has a presence across the country. In this case, it had received significant public dollars for outsourcing, and had been by the BC government or the Medical Services Commission, had been audited and had been found to have engaged in unlawful extra billing. The health authority did cancel its contract, but obtained by FOI, their lobbyist went to the Deputy Minister of Health and said, I hope we can move past these ideological differences and have a long-term, quote, long-term volume guaranteed contracts, which will enable us to make an informed decision on the long-term sustainability of this business model, end quote. And subsequently, in the following year, the two largest health authorities renewed contracts for 3-year terms. So, and I guess by way of continuing to expand on this, we saw a case at Kamloops Surgical Center, which was even more interesting in that it was audited by the Medical Services Commission, found to have engaged in unlawful extra billing, and the health authority continued to contract for insured services during and after that period of extra billing. We have the case of TELUS Health, which is a major player in British Columbia and Western Canada, and I think increasingly across this country, where we had an out-of-court settlement. The province had threatened a court injunction, and this was a subscription fee bundled service where they were basically blurring what was insured and what was non-insured to be able to kind of blur this idea that this is actually not medically necessary and therefore this is not extra billing. Actually, just yesterday, Harrison Healthcare settled out of court with the province of BC as well in a similar subscription-based primary care service. And I realize I'm out of time already, but I will conclude by saying I think we need to be attentive to this interplay and this dynamic that we're seeing across this country. We have an increasing discourse from private interests, from some surgeons and physicians, and from a number of provincial governments to say that this is a benign form of for-profit involvement in the healthcare system. And I think the evidence that I hope I've brought to bear here is that we are also seeing right now an explosion. I'm hitting my slides, but I'm not moving your slides. You know, we're seeing quite an explosion in recent years of reported unlawful extra billing, which is also coinciding, as I've shown, with an increasing desire among a number of provincial governments, all of them at this point in time, as well as a number of private interests that are advocating for much greater outsourcing. And I think just by way of conclusion, I will say that I think we need to understand for-profit delivery or outsourcing as a gateway to two-tier healthcare, because we have to understand that inherent to the for-profit business model of a lot of these investor-owned facilities is the mixing of public and private payment. So I'll conclude there. Thanks.
Very good. Thank you, Andrew. That's terrific. I'm going to just roll us right forward to the next presentation. I'd like to introduce Danyaal Raza, who is a family physician with Unity Health Toronto's St. Michael's Hospital and assistant professor at the University of Toronto. Dr. Raza is a past chair of Canadian Doctors for Medicare and founding physician lead of the Sumac Creek Health Centre in Toronto's Regent Park. Danyaal is presenting alongside Sheryl Spithoff, who is a clinician scientist at Women's College Hospital and an assistant professor at the University of Toronto. She has appointments at Women's College Research Institute and the School of Public Health at the University of Toronto. Her research explores the intersection of new technologies, commercial interests, and the healthcare system. And they together will be presenting on paying with more than your credit card, the rise of for-profit virtual care and the commercialization of patient data. And 10 minutes for the two of you. Thank you, Kevin. I just have to quick mics off. Sit on.
Hello.
There we go.
Okay, great. So we already heard it in I think Jennifer's comments a little bit earlier that we're, of course, during the pandemic, the emergency phase of the pandemic, we saw a rapid adoption of virtual care, and I think most of us would argue that this was a good thing. It allowed us to deliver a significant amount of care safely, respecting social distancing guidelines and reducing the spread of COVID. But of course, moving this quickly also had some very significant unintended consequences. And one of them has been the rise and I think now entrenchment of these virtual walk-in only style for-profit services. And these are fundamentally different than the way Dr. Spithoff or I do virtual care, where we both provide comprehensive family medicine. And for us, virtual care is one tool in our toolbox to provide care to patients in our practice, in addition to complementary in-person care. And of course, when you're operating a virtual only walk-in clinic, there are lots of clinical consequences that result, but that's out of scope for what we're talking about. Today. The paper that we're presenting, it's actually part of a larger research program that asks the question, what is happening to all of this patient data, right? That's being collected now as part of these virtual care services. Many people are also asking questions about how this data is handled by these new companies. There's concerns related to targeted marketing, the sale of data to third parties, and of course, implications for patient care, for clinical outcomes, and for equity. So the research objective here for us was to understand and report on, and this is the term that's used in the literature and that we're using, direct-to-consumer virtual care, the direct-to-consumer virtual care industry in Canada, focusing on how companies collect, use, and value patient data. We only have one slide. You're looking at it now, and depending on how you consume your information, whether it's through video, op-eds, or full research papers, you can snap a picture and feel free to revisit those after our presentation.
So to answer this research question, we used qualitative research methods. Our approach was informed by situational analysis, which is a grounded theory methodology. In situational analysis, the objective is to generate a deep understanding of a complex social situation. We had two data sources. One was interviews with people who were affiliated with virtual care platforms as employees, contractors, consultants, and the other was documents, 31 documents that we took off the websites from companies that had virtual care platforms. So participants shared with us that these companies highly valued patient data, not just as a way to provide care, but also as a revenue stream, a potential revenue stream, a way to advance their business interests. They described how during the pandemic, there was a data gold rush when companies sought to acquire startups or through mergers and acquisitions, get access to the virtual care market and hence patient data. And these platforms collect a lot of data and a lot of different types of data. Participants described to us the different types of data collected through the platforms and how the companies categorize them. And this matters because how the companies categorize them determined how they use the data. This all aligned with what we found in the privacy policies as well. So the first category or type was the sign up or registration information. So like names, email addresses, when people first access the platform. And companies classified this as personal information, but not personal health information, which has different implications because of different legislations apply to these different types of data. The other was user information, IP addresses, device identifiers, and these data also were placed in the personal information category. Then there was the information collected when patients interacted with a physician or a nurse practitioner. This was in the PHI category, personal health information. And the final category was de-identified data. So data from these other categories with the identifiers removed or manipulated, so the risk of re-identification was low. So Then companies took these data and used them in different ways. For data that fell in the personal information category, the sign up, the registration, the user data, the de-identified data, these data were considered to be on the business side. So they were used for purposes like expanding services, improving services, marketing other products and services, marketing the products and services from third parties. In some cases, the companies also share these data with third parties for marketing purposes. In particular, user information was shared with companies like Facebook and Google. Now, to you and I, an IP address or device identifier might not mean much, but Google or Facebook's able to use this information, the identifiers, and link it to a uniquely identified person in their database, and then use it for targeted advertising. Then the personal health information category, according to participants and what we found in the privacy policies, this data was generally considered to be on the clinical side and to be used for clinical purposes. However, a few companies had found a way to use this data for business purposes as well to promote products and services. So participants described how the platform they worked for had partnered with a pharmaceutical company to promote their products and services. And how they did this, they took the analysts who worked at the virtual care platform, took the personal health information, looked to find patients who may qualify for the drug or vaccine, and then targeted them with messages, reminders saying, oh, come and get your vaccine or start this drug. And it was important, according to participants, that these messages came from the virtual care platform. They're perceived to be coming from a clinical source, not from the pharmaceutical company, so that patients might be more likely to follow through with the information that was in the reminder and the instructions that they received. And then the participants described how the platform would then tweak the frequency of reminders, the information in the reminders, the clinical interfaces, and do what one participant described as A/B testing, all in order to increase the uptake of the drug or the vaccine. Okay, sorry, Dan. So study participants viewed this as happening or operating within industry norms. This was what all companies were doing who had access to data. And although some had concerns about privacy and pharmaceutical industry influence, they generally felt this was appropriate. So we asked why patients might consent to these uses of their data. And it was largely around problems with the consent process. The documents were dense, full of legalese. It was difficult to opt out of things. Participants also felt that Canadians had few other options. Many didn't have a family doctor. And also they had high levels of trust in the Canadian health system, so they might not carefully read through these privacy documents to look at what was actually happening.
And I'll just take one more minute to wrap up, if that's okay. The implications for these findings, I think, are really important. Sheryl mentioned one about how our health system's trust is essentially being used to, privatize our trust and socialize the risks, which is a phenomenon I think we're all very familiar with. There's also, of course, incredible individual and group risk. Depending on how this data is collected by data brokers and how it can even be de-anonymized, there's tremendous risk to individuals. There's an American insurance company called Aviva that was actually able to report that patients' digital traces accurately predicted their health risks. And depending on how those profiles are used, that could affect someone's ability to get health insurance or even employment if employers are using it. And then there's also community and group level risk. Where this is happening the most in the US, there are commercially available algorithms that are used to allocate and guide resources. And there was a study in 2019 that found one such algorithm used race, and it identified Black patients as generating lower health costs. And this is likely because of barriers related to systemic racism and lower income. And then as a result, the algorithm allocated Black patients fewer health resources, which of course is a totally perverse outcome. So this is a back-end thing, right? That we don't always talk about when we talk about virtual care. Virtual care is like any technology. It's like any tool. It can be used to do good things, but it can also be used to do things that are not. And its deployment is critical, right? The legislation, regulation, and professional standards. But something else that Sheryl said, I think really stuck with me, and that's that we shouldn't accept self-governance, right, as one of those tools to govern the way these companies behave, because these data practices are considered within industry norms and by many industry actors appropriate and or totally expected. So when it comes to these virtual only for-profit walk-in clinics, I think we need to pay close attention, not only to the patient-facing experience and the charges that they're being charged on the front end, but everything that's happening in terms of commercializing their data on the back end.
Thank you very much. You know, I struggle as a moderator with issues of such gravity and obviously researchers with real depth. I'm sure we could hear all of these folks speak for 30 minutes, 45 minutes and have, you know, a lot of good discussion. So we're asking them to sandwich everything into 10 minutes. It's kind of unfair, but at least we get a jam-packed session. So I will move now. Rebecca, you're okay? Oh, yeah, no problem. I'll just take a second then to introduce Rebecca Graff-McRae is with the Parkland Institute, a researcher. She will be presenting on innovation, guinea pig or canary in the privatization coal mine, a case study of medical lab services in Alberta. Rebecca is the research manager for Parkland Institute at the University of Alberta, where her areas of research include public health care, seniors care, and public services. I'll just add, I'm looking forward to this in part because for a particular reason, maybe I'll share afterwards, I have been following the roller coaster, as she put it, of medical lab services ownership and policy in Alberta for a couple of years. So look forward to this presentation. Rebecca, go ahead.
Thanks very much, Kevin. I'm going to try to skip ahead here. And I'd put up this quote here from Joel Dryden at CBC in relation to the provincial election in Alberta, which was a year ago last May. What I think really speaks to some of the challenges that were highlighted in our previous panel and by my colleagues up here on the panel as well, but where we're going to see those increasing battles around the blurred lines, the gray areas within our healthcare system and how those are ramping up. So I'll leave that one with you. In some ways, I think lab services has been done a disservice because it has been so entrenched within mixed delivery, different formulations of private and public delivery and private and public ownership in various different configurations, both in different provinces and, as you shall see, in Alberta itself. So I'll make the case for why. Oh, forgive me because I've left some animations on there. There we go. It's one of my favorite pictures to talk about lab services in Alberta. That was an actual car crash at a Danyaal collection site that took place before it was metaphorically car crashed last year. So enjoy that for now. So nearly a year ago, Danielle Smith's UCP government made an unexpected and certainly uncharacteristic policy reversal, bringing all contracted medical laboratory services under the Provincial Health Authority, AHS, and its subsidiary, APL. As corporate provider, Danyaal ended its contract just 8 months in. So this period was fraught with certainly an onslaught of headlines, months-long delays in the transition to operations, drastically reduced access to appointments, round-the-block queues for walk-ins, multiple labor disputes with the union, HSAA, and reports of delayed results, and in some cases, tragic errors. And while some observers raised eyebrows at a conservative government, a self-professed libertarian government, effectively nationalizing this key healthcare service, under the surface, the move was actually entirely in character for Smith. It was motivated by short-sighted political optics over evidence, expertise, or effectiveness, and a prime example of doing the right thing for the wrong reasons. So it was also not the beginning of the saga of lab services in Alberta, what I like to affectionately call a series of unfortunate events, and nor realistically is it likely to be the happy ending. So as you can see from behind me here, the roller coaster that Kevin alluded to, the saga begins sort of in the early 90s with former Premier Ralph Klein when he imposed sort of swinging across the board cuts to healthcare budgets. And in lab services, that meant an effective 20% cut over the space of 3 years. It essentially prompted a generational exodus from the workforce. And over the next 2 decades, lab services really had to limp along towards recovering from that initial blow, which was hampered by chronic underinvestment, persistent infrastructure deficit, as well as a number of further transitions in the ownership and delivery of that service provision. So I'll skip over some of that, but just to sort of name the previous major players and the key milestones here, that in Edmonton and some of the northern communities, the sector was dominated by the companies that came to form DynaLife. Previously were DynaCare Casper Medical Labs, which merged with Life Labs to form DynaLife. And in Calgary, in particular, there was a initial public-private partnership to form Calgary Lab Services. Now, for those keeping track of the history, because it matters, in 2006, those private sector investors pulled out of that partnership, leaving the future of Calgary Lab Services sort of up to fate. What was then the Calgary Regional Health Authority had to step in to buy out their stake. What actually became a very unique and often emulated model that was quite successful in Calgary Lab Services as a wholly public subsidiary, even under Alberta Health Services, which became. So in 2014, 2015, the previous Progressive Conservative government dropped a request for proposals to contract out the majority of laboratory services in the province. That was initially awarded to Australian company Sonic, but due to a number of inconsistencies within the proposals process and a lawsuit from DynaLife, that award had to be canceled right at the time that the government was changing, and the incoming NDP government tried to mitigate the fallout from that cancellation. They turned to an sort of independent body, the Health Quality Council of Alberta, to study best practice, the evidence, ways of looking at reshaping lab services system in the province to be more efficient, less duplication, and more stability, dare we say. So in 2018, they formed what was called Alberta Public Labs, and we're moving towards implementing a province-wide, wholly public, hub-and-spoke model. And then in 2019, we had a change of government. This is going to be a recurring theme. And oddly enough, one of the key platforms in Jason Kenney's campaign was the cancellation of what was being called the Super Lab, the Edmonton Clinical Hub Lab, as some kind of government boondoggle, that this lab infrastructure was a huge waste of money that could be put into, quote, frontline healthcare service. Lab workers took exception to that. So when Kenney government came in, one of the first things they did was to kibosh the Super Lab. Even though ground had already been broken, they paid multi-millions of dollars in fees and penalties, over $37 million, to fill in the hole in the ground. And it went on. So some of the things that have happened since then, a few months later, the Kenney government arbitrarily decided to change the name of Alberta Public Labs to Alberta Precision Labs, which is what remains today, apparently just out of a preference for not including the word public. So we could see there, since all of these things happened, we had a pandemic in which lab services were highly involved. And the Kenney government decided to sort of rerun that 2014-2015 proposal to contract out lab services. Here's where DynaLife comes in. Since then, DynaLife was awarded that contract in 2021. They were supposed to take operation in June 2022. They had to delay that by 6 months due to staffing pressures. And when they eventually began that transition at the end of December 2022, what followed was 8 months of politely termed chaos, which brings us up to some of our first lessons here. My series of unfortunate events here and what ensued during that period of chaos and leading up to Smith's announcement. So the first lesson that I'd like to offer for you is that disruption is compounded by history, by concurrent challenges in the healthcare system, and by each policy decision that's made, or in these cases, reversed. The system can only absorb and adapt to so much before it reaches a really critical tipping point. And that's especially true with regards to its workforce. Need to be a little bit more forceful with the buttons. I don't know. Okay, we'll leave this one here for you. So throughout all of this process, there has been a very marked lack of consultation with lab workers. In the last 5 years, for lab to be utterly blindsided by government announcements that impact their entire existence has come to be the norm and not the exception. My friends in lab have often said to me they dread going into work on a random Thursday morning because that's when bad news gets buried. So this has serious implications for implementing change and for the sustainability and resilience of the workforce. So long after such announcements are yesterday's news, what we see now within the lab workforce is a deep sense of demoralization, pervasive uncertainty, dealing with logistical pressures around changing employers, changing unions, changing sometimes the location of their job, the ongoing labor disputes that I mentioned earlier, on top of pandemic burnout, a demographic shift within the workforce that's happening nationwide, and there's an overwhelming sense of being used as a political football. Oh man, sorry. I'll try to be super fast. But also, this is deeply important because lab workers hugely value doing their job to the very best standard and following the evidence, following best practice. And during this time of upheaval, lab workers and observers of the history I've outlined have repeatedly raised these red flags over the proposed changes and highlighting the potential impacts to their patients, their colleagues, and their ability to deliver quality services. So that's the context in which this mayhem that characterized the DynaLife transition took place. How many times lab workers had to say, "We told you so." So the fourth lesson that I'm going to lead into my conclusions here, I think is the most difficult for me as a researcher, and perhaps for many of us in the room, is that evidence doesn't matter. What we've seen over and over again, yes, most glaringly from successive UCP governments, but even prior to that, with progressive conservatives, of prioritizing this illusion of cost savings over the real costs to patients or workers or the system viability, emphasizing a narrative of free markets and choice and innovation, and de-emphasizing the bailouts that come after, and sacrificing quality, coordination of delivery, and stability of the system for cutting corners to promote the balance sheet. And with that comes a distinct lack of transparency and accountability. After the absorption of DynaLife by APL, the Auditor General of Alberta was tasked with producing a report on what happened here, who could have foreseen. Unfortunately, the AG's report has been delayed several times due to a lack of available data and also a reluctance among key players to collaborate or cooperate with the Auditor General's office. Meanwhile, the costs of that cancellation were only revealed as a line item in the 2024 provincial budget and only included the cost of buying back equipment and collection sites. So the insight that this offers to us as we come into another round of, another round of change for change sake, destabilization, the deconstruction or restructuring of Alberta Health Services that was announced by Smith last fall looks to be repeating the same patterns and mistakes. I think is it Marx who said first as tragedy and then as farce. Lack of consultation, no basis in evidence or justification. There's no mention of lab in any of the successor bodies to Alberta Health Services. No consideration of labor concerns, and heedless of the financial costs and the wider costs in terms of uncertainty and destabilization. And my very final point for you, when I asked my lab worker friends, family, and colleagues who've worked in lab for many years, I said, what was the one thing that you would like the folks in this room to take away from the Alberta experience? And sort of gut-punchingly said, nothing is sacred. They were the heroes of the pandemic. They were hailed as an essential part of healthcare. 70 to 80% of all medical decision-making relies on laboratory services. And said, nothing is sacred. They're expendable, and we all have to be prepared to fight for every part of it. Thank you.
Thank you so much, Rebecca. I have many questions that I won't pose to the panel. And in fact, I think we still have 15 minutes or so for questions. So please prepare your questions. We've got the microphone there. As we transition to questions from the audience, I will just tack in my one personal connection to the story that Rebecca just shared. And I think it will be of interest. As a pension researcher and pension-oriented person, I'm always interested in issues of ownership and, what we call the financialization of these things, financialization of public services and so forth. And I happen to have a very peculiar direct connection to the Dynalife adventure that Rebecca shared, which she touched on very briefly, but I want to just elaborate on the one point. She mentioned that one of the elements of chaos in the transition from the public service to the Dynalife contract was labor disputes and HSAA. In fact, CUPE also represents some workers in the lab services. And there was a major dispute, and I want to share what it is. Dynalife, when it won the contract in the year that Rebecca mentioned, they were taking over the larger section of the lab services that were in fact unionized and in the public sector. It came out when they went and sat down, their successor rights, and they were taking over contracts and collective agreements for lab service workers. And one of the things that they said to the unions after acquiring their facilities was, we have successor rights and legal obligations to respect your contracts as they currently sit, but there is one exception to our recognition of your successor rights and your contracts. And that is, there's this line in your collective agreement that says that you will be provided with the pension plan of the Alberta Public Service, local authorities pension plan, one of the large public sector pensions. So those lab workers were pension plan members. And they said to the workers, we'd like to delete that line in your collective agreement and replace it with a RRSP scheme that costs us about half the amount and has no risk on the employer. What do you think of that? The unions did not think much of that. And they said no and fought this ferociously. Dynalife tried to take this dispute to the Alberta Labor Board to try to get the labor board to sanction them rewriting this contract. Fortunately, the Alberta Labor Board said no. But here's the ultimate irony and the real piece that I want to share. Who is Dynalife? Who was it that's doing this? Dynalife, in fact, is a corporation, a private equity corporation that in fact has two corporate owners. The majority, 58% of the equity of Dynalife is actually owned by OMERS. OMERS is the Municipal and School Board Workers Pension Fund of Ontario. And it invests the funds of public sector workers in Ontario. And I have a personal connection to this because I happen to be appointed to the fiduciary board of OMERS by CUPE. And CUPE represents workers that are being threatened with losing their pension plan. So we have this, well, and I won't editorialize too much. I actually have confidentiality obligations, but all of this is public. And I share this because I think it does add additional color to this process and like who some of the sharks circling the healthcare system are, who would really like to sink their teeth into these services, facilities, and public funds. I'll stop there. Thank you to the panel. This is great. We do have a bit of time left. To the floor.
Thank you. My name is Philippe Crevier. I'm working for the big union in Quebec, representing hundreds of health care workers.
Which union?
It's the Health and Service and Federation affiliated to the CSN.
CSN, okay.
Yes. So I'll try to make my point with it's kindly that I'm telling that to you and with a bit of humor, and I'm reacting to the first two panels. I was joking with my colleague while the first panel was on that we felt like in another country because in Quebec, private is everywhere. It's not here and there, it's everywhere. And there's even a new agency that has been made in place a few weeks ago with a private clinic network owner at the head of this agency, and with a former an actual hotel resort owner at the head of the administration council. And it's written black and white in the law that the objective is to get the privatization going on more freely. So we have hundreds of private clinics in Quebec that get private payment to go on, and almost hundreds of physicians that are not affiliated to the public financing. So we're feeling that there's a real emergency in Quebec, and is that the law, which is the 40th anniversary today, is to prevent a private wildfire in Canada. It's time to get the focus on what's happening in Quebec, and apparently it doesn't work really well, the law in Quebec. So we were thinking maybe the next event should be held in Quebec so we can present every. I could stay all day long to present you all the forms and the hybridization of ways that the privatization is going on. Very rapidly, another thing about the health data. There has been, TELUS Health. There has been a conference in Quebec a few weeks ago. And these, the press conference, the press release was very clear about their intentions. It was about how AI is reshaping the health and service landscape. And they are, and I'll read this to you. Speaking of AI and all the technological evolution in the system, the stage is set for private payers to take the helm in driving healthcare transformations. So, and I'll conclude with that. If the in the first panel, I think I've understand that we were thinking about the evolution that the health Canada health law could get. All the notion of a publicly held data, health data and AI system, it's absolutely necessary because it will be a powerful tools to get the privatization. I'll practice that tonight. Taking form in all the country ultimately. So thank you.
Very good. Merci beaucoup. Before we get responses, I think it makes sense because we're running out of time a bit. Let's hear from the remaining people at the mics, and then we'll offer responses from panelists to wrap. So go ahead.
Okay.
Please introduce.
My name's Lance Livingstone. I'm a Unifor retiree from Oshawa. I'm also a co-chair of the Durham Health Coalition for the Ontario Health Coalition. My question is about the virtual doctors doing this. So I have a Unifor friend, retiree. He didn't realize his medicine lapsed. So he had a phone to try to get in there to get a new prescription. And of course, now you can't do it. Most doctors now want you to come in because that's how they're making money now. Where I remember doing that when I was one family doctor I had, he would just send it in for you. But now they don't want to do that because they want to get paid for you to visit. So I have no problem for that because doctors need the money. They're not getting paid enough to me of all the stuff they got to do. But what happened, he couldn't get in the doctor and needed a prescription because they said it'd be 2 weeks before he could see the doctor. So he decided to phone the virtual doctor instead of going to see the drugstore to see if he can get it extended, so many pills, because I know I've done that. When he's seen the virtual doctor, the doctor phoned in a renewal for him. And then when his family doctor found out that he did that, and as we know, there's a shortage of doctors in Ontario, he just said, I don't want to see you anymore. You want to go use your virtual doctor then. And then now he's worried because he sees specialists. How is he,
going to get referrals?
I think that's a problem with virtual doctors.
Very good. Very good point. Thank you. Marc-André, so the last question to the panel.
So thank you. More of a comment, especially with the two first presentation, but thank you for the. Okay.
Just closer to you.
Thank you for the great case studies. Maybe a question for the first two presentations. More of a comment. Patient support programs, basically. It's just, prescription drugs is not covered under the Canada Health Act, but infusion clinics are supposed to be. And now it seems that the new dominant model in terms of putting to market new expensive drugs, biologics in particular, comes with patient support programs. So a series of benefits, privileges you're offering the patient. So the way it works, basically, when the doctor prescribes this drug, this biologic that comes with a patient support program, you don't give the prescription to the patient, you send the prescription to the patient support program that will take care of the patient. But this patient support programs is managed by Innomar Strategies or Bayshore, basically for-profit companies hired by the drug company. And then specialty pharmacy will contact the person and, okay, you can now get your drug at this special infusion clinic we're putting for you. You're not paying anything out of pocket. But now you're getting treated directly by the drug company that is offering the product. All your health data goes directly to this drug company. And most provincial governments basically promote this because, well, we don't have to pay for the infusion clinic. These are these little services offered by the drug companies. So this is great. And at the same time, so working with a research project with Quinn Grundy, what it means in terms of the impact on nurses as well. It's just more and more nurses are being hired by these patient support programs by a for-profit company to provide specific care as long as it continues to make profit for the distributor. So I'm just mentioning this because when we talk about creeping privatization, this is very blurry. This is not in the Canada Health Act, but this is huge when it comes to prescription drugs at the moment, and there's no freaking literature about this. So, thank you.
Thank you, Marc-Andre. Maybe that's a gap that you can help fill. Yeah. Okay, we're kind of at time, but I'll invite each panelist to offer, a quick word in response to any of the questions that have been raised, and this will be our final round.
So with respect to virtual care, it's not happening in a vacuum. I mean, there's these gaps in our health system, and rather than fixing them, governments and other players are allowing these private sector companies to kind of step in and offer these services. And there's no doubt that they are addressing gaps, but we have to think about at what cost. So that's my final point on this. We should think about shoring up our primary care system so that people don't feel that they need to use these privatized services. We should look at countries like the Netherlands, some of the Scandinavian countries where they have excellent coverage for primary care and people can get timely access.
Daniel.
And, I heard two related themes in the questions. One was virtual care, right? And one is patient data. And they're actually, even though they're related, they're distinct things. Virtual care has risen so quickly, its rapid adoption made sense, but now it still feels very much like we're in the Wild West. But I think my concern is, and we heard that from the comments around, being fired by one doctor because of using another doctor. We need rules, we need legislation, we need regulations, and if we don't make them, then the damaging practices we're seeing now will just become the standard, and the rules will be made by commercial actors. So that is something that we need to be aware of. We need to act before this current behavior just becomes accepted norms. And then the other thing around patient data is, Sheryl and I co-presented this, but this is Sheryl's lab who's doing an amazing amount of research on what's happening to patient data on the back end, not just through virtual care, but through other things. So there is more to come on this. So we hope to be back to talk more about how data is handled, including in unexpected ways through, for example, Marc-Andre, the infusion clinics, because, the public payers are trying to solve one problem by moving this cost off the books, but then there's this back end problem where they're essentially then unknowingly subsidizing the drug companies by giving them access to this patient data. And one of the questions I have is that even a consideration? And if it is, would it change the agreements that the public payers make with the drug companies when they're negotiating, medications that need to be given at infusion clinics? It's again, like, this area of technology that's moving very fast, where we need to make the rules before the commercial actors entrench practice.
Very good. Thank you, Daniel. Andrew, just if I could, just quickly.
And I don't want to say anything more.
You've got nothing.
I've got nothing. It's all been said.
Okay, very good. Rebecca, a final word?
Yeah, I think I would only say that perhaps the lab services example and many others presented here illustrate the ways in which so many of these policies are now governments attempting to solve problems of their own making or of their predecessors' making by thinking about these short-term political optics or whatever, like say, removes a line item from the budget for this year so we can declare a surplus, or it's a result of many, many, many years of not having a long-term perspective on what the foundations of good healthcare are for Canadians, and how not just to sort of protect those from the most obvious forms of erosion, but how to ensure, as we heard this morning, how to ensure that those are able to grow and adapt with these changing conditions. And I think that's where some of the challenges we are going to see in the future.
Very good. Thank you. Let's leave it there, folks. Join me in thanking the panelists for this session. It was terrific. I will turn it back over to Steve.